suggestions for how we might do this better is also appreciated. Actually, I always viewed our work as music rather than education. I like just the feel of it. And to me, like we're just trying a different kind of music, different singers, whatever. So I'm just kind of trying to figure out how the music sounds here tonight. Anyhow, so Swati, here's a pretty interesting question that we see more and more. It was so exciting to finally see something that sort of semi worked in HCC, atezo-bev. I remember when that first came out, I wasn't even aware if it was presented in an Asian ESMO conference. Next thing I know, everybody was using it. But then last year at the ASCO GI meeting, we had another phase 3 trial using a combination immunotherapy, anti-CTLA-4, anti-PD-1, durvalumab, tremelimumab. Common problem in oncology. You got to compare two trials indirectly. Which one would you use? I was asking Dr. Goyle, of course, everybody's used to atezo-bev. What are some of the situations where now she's thinking about durva-tremi?
Given atezolizumab plus bevacizumab has a VEGF inhibitor as part of the regimen, I always think to myself, do patients have any relative contraindications to getting a VEGF inhibitor? So I find that if people have had recent significant bleeding, if people have at baseline relatively uncontrolled hypertension, despite, for example, 3 antihypertensives, and I worry about them developing further hypertension on the VEGF inhibitor, I think twice about that regimen. If people have significant proteinuria at baseline, that's hard to get on top of, I think about that. Also, of course, in our population, we see people with varices. And so if people have varices that can be treated and, can move forward with atezo-bev, that's my first choice. But if they have, let's say, grade 3 varices, and we ban them, and they're going to take some more time in order for it to be safe for the patient to be treated, but the patient is having pain, for example, and more urgently needs to start on therapy, that's the kind of patient that I would, treat the varices because I want to be able to give them a VEGF inhibitor in the future. But it might make sense to start with durvalumab and tremelimumab up front. If someone has, advanced heart failure, for example, it might be a patient that I'm less likely to use bev in. But even some people who have coronary artery disease, even if someone has a history of a CABG, I think it's still reasonable to give a atezo with, an immunotherapy regimen up front, specifically with atezo-bev if they're candidates, otherwise with durva-tremi if they're not candidates. And there are a lot of really smart groups trying to assess the impact of etiology on outcomes now.
So Swati, of course, first kid on the block always gets a lot of attention. People have a lot of feelings about atezo-bev because we really had just sorafenib before. One thing that she mentioned that I thought was relevant, people bring up the issue of toxicity of durva-tremi, and she pointed out that whereas ipi-nivo, let's say in melanoma and other cancers, is maybe a 50% chance you're going to end up giving corticosteroids for autoimmune problems. With this, where you're only given one dose of the anti-CTLA-4 in the beginning, it's more like 25%. So still, important. Any thoughts about how you're processing this decision? I don't know how often you even see HCC, Swati, and what your thoughts are about this type of content in terms of whether it's helpful to you.
Absolutely. So I don't see a whole lot, but I have seen a few patients with HCC, and I think it's really nice to have two great options. The atezo-bev, of course, transformed our practice overnight with overall survival benefit and a very high response rate of 30%, which we really hadn't seen. And then came the durva-tremi, also with OS benefit, and I think a response rate of 20%. So also a very effective combination. And I agree completely with Dr. Goyle. It really comes down to individual patient comorbidities, what their, if they have any autoimmune problems, do they have any bleeding complications? I think it really comes down to managing, looking at their comorbidities and then picking one regimen that is well suited to them. And I think lenvatinib is still also an active player. I have seen patients who have contraindications to immunotherapy where I've had resorted to lenvatinib. When I'm thinking about choosing the first line regimen, I do get a varicose screen, make sure I know if they have varices, they're banded. Then I look at does this patient have contraindications to Avastin? Do they have uncontrolled hypertension? Do they have like a recent stroke? Do they have a thromboembolism, recent clot, which will give me pause to do the atezo-bev? But a patient who does not have any contraindications, I think still atezo-bev will be my first line go-to. I mean, cross-trial comparisons, I know we shouldn't be doing, but the response rate of 30% is the highest that we've seen when I compare it to other regimens like durva-tremi. But if I am concerned about the bleeding risk, then with bevacizumab, then I think it's very nice to have durva-tremi as an option. And comparing this to nivo-ipi, like you said, from what I understand, the rate of steroid use with durva-tremi was still much less compared to the nivo-ipi combination. So yes, there is risk of autoimmune side effects, but not as high as as we see with nivo-ipi in the melanoma world. So, and as far as the etiology that you brought up, I think it's very interesting. I think there is a signal there that maybe TKIs work better in patients with NASH cirrhosis, but unfortunately, I don't think we have any studies specifically powered to look at this, but I do think we need to do those studies because in the US, I mean, the etiology for HCC is mostly in the setting of NASH cirrhosis rather than viral mediated.